Thank you very much. Good afternoon, everyone. Again, my sincere thanks to the organizing committee and to the President and Organizing Secretary, Dr. Vijay Kumar, for this invitation. When this talk was first given to me as translating research into practice, I thought it was some general topic till I found out it was in the GDM session. I'm really happy to be doing this. Next slide, please. I think I can do this myself. Yeah, what I'm going to do is just to talk a little bit about what is this translating research. And everyone in this room knows that research is sacrosanct and research can be transformative. It is transformative only if we analyze it, study it, and apply it to our practice. So it can be transformative. And some examples in GDM research and translation, and where it has caused a paradigm shift in the way we do things, and where it has caused some confusion. And I'm really grateful to Dr. Sushil Gupta. I think he set the stage very well in terms of the oral hypoglycemic agents and gestational diabetes, and where it should be really not a paradigm shift, but it should be making a seismic kind of shift, but it's not happening. So that is really going to be the crux of my presentation. But we all know what this whole evidence-based practice is. It's not a blind following of research findings. It is an integration of best research evidence with clinical expertise, and of course, more importantly, patient values. How we marry all these things, I think, is really the sign of a good clinician. And so just to put it in perspective, where this translation is happening, there's basic and clinical research, and of course that then goes on to how we apply it to practice, and finally to improved health of our patients. So there's basic research, and then there's clinical research, and then there is this application and improved health. And where the problem is really not in basic research to clinical research, but in clinical research to application of findings is where we find the what we call lost in translation. So just to put it in perspective, things start with a little idea, and then it becomes a research project, then it becomes a journal article, and then there are systematic reviews, then there are clinical guidelines that are made by our professional societies, and then there is clinical procedure and quality improvement, and then it comes into everyday clinical practice. So it has to trickle down finally to everyday clinical practice and then change the health outcomes of our patients. And as Sushil has said, we're really talking about two people here, the mom and the baby. And why I bring this up is when we are talking about research in gestational diabetes, the loops, then the hoops that we have to jump with ethics committee and others to make a research project happen. All of you who have done that research know that. So it is very important that we take into account the health of both of these individuals. So the evidence is very, very clear in this. For example, for a long time people said, if GDM is something so common, so mild, nothing happens, why even treat it? But then this wonderful study, the ACHOY study, which showed us that where they looked at comparing the diet and capillary blood glucose monitoring, insulin versus routine care, and looked at serious perinatal complications, and were able to show that any serious perinatal complication was significantly reduced. It is after this landmark study, and I want to tell you here, we cannot replicate the study anymore. No ethics committee will ever approve this study again, but we have to take this particular study, which has shown that treating gestational diabetes improves outcomes. So this is a study that has made a big landmark difference. Then comes this HAPO study, or hyperglycemia and adverse pregnancy outcome study, 25,000 plus patients in 15 centers and 9 countries. India was not one of them. Huge study. What I think it really brought into our radar, the practicing physician, is not that there is some finite number or some point of inflection above which there are complications and below which everything is okay. What this particular study showed us was it's actually a continuum, that there is normal and then there is those clearly abnormal values, and everything in between. Actually, there is a continuum where it could cause deleterious effect for the mom and the baby. Again, to mention what Sushil had said, that it's really important to make the blood sugars of the pregnant mom as close to a normal, non-diabetic pregnant mother. That's when we can expect the best kind of outcomes. And again, to show you that how somebody has taken this and applied it, they have taken the IADPSG guidelines, introduced it into screening and diagnosis, and what they've shown is improved outcomes and lower cost in a large cohort of pregnant women. So this was just published very recently, and to show you that be it gestational hypertension, prematurity, large for GDM, large for gestational age babies, admission to intensive care unit, they were able to show a decrease in all of these things. This is the essence of good clinical research, when we are able to take it and apply it. Now, coming to where evidence has been cloudy and contradictory, again, I think this has been brought out very nicely. Though Oded Langer showed that when you compare glyburide with insulin, it was only 4% of people needed insulin, and when they had those secondary outcomes, they were matched for insulin versus glyburide. But subsequently, we have a lot of data where it showed neonates born to mothers on glyburide more likely to be macrosomic and to be admitted to the NICU. Then we have this most recent study that was published in JAMA Pediatrics, which showed that NICU admission, respiratory distress, hypoglycemia, large for gestational age, were more with glyburide or glibenclamide. And again, the new BMJ article, which is a fantastic big meta-analysis, which has shown that on this side it favors insulin when they compared it with glyburide for many of the outcomes that they measured. So really, this is where I think we need to look at what the guidelines are saying, what the groups that have analyzed all the data, and not just go by a single research study that comes out. Now coming to, and again this is for neonatal hypoglycemia, this is the BMJ study. Now coming to the most important area that I want to spend time and stress is when we have this all breakthrough and no follow through. We have all kinds of research, all kinds of findings. Everything seems like big, eye-opening, path-breaking findings, but we don't do anything about it afterwards. So let me show you an example, and I know that Dr. Anuj Maheshwari is going to talk about preconception care and postpartum care, but this is where clear evidence is there, but very, very poor application. We know that when women get gestational diabetes, they are at greater risk for future gestational diabetes. You can see these GDM people, future 72%. Even the ones who did not have GDM, 21% having GDM. So high conversion rates, especially the ones with GDM who have future, they are more prone to future GDM. We also know that these are women who are prone to future type 2 diabetes. All kinds of studies have come out, studies from South India, studies from Chennai, studies from other parts of India, and global studies which have all shown in the first 5 years after the index pregnancy with GDM, as much as 50% of the women go on to develop type 2 diabetes. And those numbers can be higher if the woman is older, heavier, comes with a family history of diabetes, has PCOS, or just allows herself to gain a lot of weight. So this is something, again, very, very clear for everyone to see. Also, some new evidence to show increased risk of cardiovascular risk in women who have gestational diabetes. So it's not just future GDM, it's not just future type 2 diabetes, it's also increased risk of cardiovascular disease, where they've clearly showed the odds ratio for cardiovascular disease is 1.85. And just to show you in a graphic, in a cartoon, you can see that there is an increased risk of cardiovascular disease. So, and prevalence of 2 or more of CV risk factors like obesity, hypertension, lipids by postpartum categories of glucose tolerance. So as they have these abnormalities, increased risk of CV risk factors also present in these women. So what can we do about this? Those also have been studied and laid out very, very nicely. You can see that encouraging breastfeeding not only helps the woman to keep her weight down and other benefits, actually decreases the risk of future type 2 diabetes. Encouraging women to undergo glucose testing postpartum period between 6 and 12 weeks. How many of them do it? A very small number. And that is because we do not from the beginning tell them that they are at increased risk for type 2 diabetes in the future. The question that is always asked at the time when the woman is told she has GDM, oh, this is only pregnancy diabetes, right? It will go away. And we all shake our head saying, yes, it will go away. Nothing to worry. Don't worry about it. That sets the tone for the rest of their life. If, on the other hand, we say your blood glucose may return to normal, but this is a wake-up call. This means you are at future risk for diabetes. If we start saying that from the beginning and setting the tone differently, these women will not let go of the diagnosis of type 2 diabetes in their future from their head. So there is this lifestyle intervention after pregnancy. Some may need pharmaceutical intervention. So this is very important for us to keep reminding our women at every opportunity we get, at the time of diagnosis, at every visit, at the time of discharge, at the time they come for a postpartum checkup, at the time they come for their immunization checkups. At every time we have to keep harping upon this increased risk of type 2 diabetes, and also keep them as a cohort that we keep following for the future, and not let go the moment she has a healthy baby. Everyone is happy. The OB/GYN is happy, we are happy, mom is happy, all the way around everyone's happy. Then out of sight, out of mind. So it's really important to keep them in our, in our radar all the time from then onwards. And why I say all this is, women seem to be at particularly vulnerable. When they get diabetes, they are more vulnerable than anyone else. And you can see that there's elevated risk of cardiovascular disease in women even prior to clinical diagnosis of diabetes. And the mortality that women have is much higher, and this is across the continents. I'm just showing Southeast Asia. More men have diabetes, but more women die of diabetes in all continents, more so in Southeast Asia. And why is that? It's because of their risk of cardiovascular disease. And how can we prevent that cardiovascular disease if we don't let them get the type 2 diabetes in the first place? And how can we do that? Catch them when they have gestational diabetes. And for all of this, we have wonderful research, but we don't apply it. So this, I really want to end here by saying the wisdom is, this is Da Vinci saying, I've been impressed with the urgency of doing. Knowing is not enough, we must apply. And being willing is not enough, we must do. So to conclude, what I want to say is, this is from the Harrison's textbook of internal medicine. This was discussed by Dr. Lafont in his Shattuck lecture, which he called as Lost in Translation. He was supposed to speak on translating research to practice. But he called it lost in translation. He said there is a huge translational highway where there is information, all kinds of research findings, and how do we, sift through all of those things? How do we take what is important for our patients and apply it in our practice? So what they said is, the practice of medicine combines both science and art. The role of science in medicine is very, very clear. What may be less clear is the art of medicine. The art of medicine is the combination of medical knowledge, intuition, and judgment. So thank you very much.